and gentlemen, I would like to thank you all for your attendance this morning. My name is Abiar Al-Wail. I will be joining my colleague Dr. Hassan Jawahiri this morning as chairpersons for the session. We will be starting this morning's sessions with Dr. Ahmed Siddiqi's presentation titled Marginal Bone Loss Around Implants, Factors, Causes, and Consequences. Dr. Ahmed is an American board-certified periodontist. He graduated from the University of Oklahoma, and he is currently practicing in Al Amiri Specialized Dental Center. I would like to kindly remind you that if you have any questions, please feel free to ask them towards the end of the presentation. Without further ado, please welcome Dr. Ahmed Siddiq to the stage with a warm round of applause. Thank you.
Assalamu alaikum. Good morning, everyone. It is my sincere pleasure to be here today to present in the Kuwait Dental Conference 2022. So let's get started since we're already I think 2 minutes late. So my subject today is going to be marginal bone loss, factor, causes, and consequences. So I will not be focusing on pre-implantitis, but on the marginal bone around implant aspect. So, as Vince Lombardi said, perfection is not attainable, but if you chase perfections, we can catch excellence. So, in implant dentistry, we always now aim into success, and success is important in regard of functional, aesthetic, patient outcome. So, why it is important? What's the importance or significance of marginal bone around implants? And later we're going to talk about factors, what factors that we can avoid, what factors we are expecting to have more marginal bone changes around the implant. And then what's the implications, how to improve. But to start with, I'm going to start with the definition of health and peri-implantitis from the marginal bone aspect. I'm going to focus on the marginal bone aspect and the concept of peri-implant bone level and its significance. So in the World Workshop, and the latest definition, for the peri-implant health, what has been defined as, so it has to comprise of core of connective tissue covered by either a keratinized or non-keratinized epithelium. The peri-implant mucosa usually average from 3 to 4 millimeters in height, and you have the junctional epithelium that facing the implant surface, and the infrabony part of the implant has to be in contact with the mineralized bone around 60%, while the remaining portion facing the bone marrow vascular structures and fibrous tissue. So during healing following implant installation, bone remodeling occurs that may result in some reduction of marginal bone. So we know from the definition and from the biology that bone remodeling occurs as part of normal healing. But how we define the normal healing from the pathological or something that's out of normal? So in regard of pre-implantitis, the clinical definition has to have the following criteria: the presence of signs of inflammation regarding profound bleeding, redness, and radiographic evidence of bone loss. So we know that marginal bone loss is one of the criteria to define disease. And increasing probing depth. And by the definition, when you don't have the original or the baseline radiographs, usually the radiographic bone level equal or more than 3 millimeters combined with bleeding or probing, and probing depth more than or equal to 6 millimeters is indicative of pre-implantitis. So marginal bone loss around implants. What's the significance? It's one of the criteria to identify disease, and also it's one of the criteria to assess the success of dental implants. So now we don't only aiming about implant functionality, but also about the implant success. And the implant success can be divided into 3 parts: the functionality, the aesthetic, and the patient outcome. And also it is important prerequisite for the preserving of the integrity of the marginal or gingival margins and the interdental papilla. So it will affect also the aesthetic. How we do assess the bone level? So usually it has to assessing the crystal bone level changes over time. It's one of the definition that in pre-implantitis, the bone changes or the bone loss has to be progressing over time to discriminate and disease. So a baseline, when the suprastructure is in place, that's considered the baseline X-ray. One other factor is, could early marginal bone loss be indicative for pre-implantitis? You will have many cases that you would have bone loss in the early 6 months that is beyond normal, that what you are used to. Is that indicative of pre-implantitis? Until today, there is no consensus or there is no agreement, but there is a couple of studies that could show either way. So one of the studies by Galindo Moreno, when they looked about the implant success beyond the 2 millimeters. So they're looking about the implant success from the marginal bone aspect. So they wanted to differentiate between physiological bone loss and pre-implantitis bone loss. So they had two groups, and these two groups, where they divided them into high bone level losers or bone loser types and low bone losers type, according how much bone they are losing. So what they found that the marginal bone loss is actually increasing with time. So this is one thing that we know. Over time, we are expecting more bone loss compared to like a 2 years implant to 4 years implant. And also what has been shown, like in the progression, usually in the first 6 months, there is a quadratic increase, and then it goes back to the normal rate. And what they found also, connection type had an effect, time, smoking, and interaction with bone loser types with time. And in regard of the question, does the early marginal bone loss could be indicative? What they came out is the number. I don't want you to focus on number, but focus on like, could actually early marginal bone loss be indicative for future pre-implantitis? What the number came out from their regression analysis is 0.4. Let's say 0.5 millimeter at the 6 months. So 96% of the implants showing more than 2 millimeter bone loss at the 18 months follow-up actually showed more than or beyond the cut point value of the 0.04 millimeter at the 6 months. And also another study, so another group is by Jerks. When they looked at the progression, they saw when they have just pre-implantitis implants, and they looked at the progression of marginal bone loss. What they found that it's not linear, it is accelerating pattern, and usually the onset occurs within the first 3 years. So again, we are talking about showing early signs. And usually bone loss more than 0.5 millimeter occurs in 50% of pre-implantitis in the first 2 years. So why it is important? It is prerequisite for pre-implant success. That's going to be always our aim. Marginal bone loss at early stages could be indicative of pre-implantitis. Just there is no total agreement on this. And compromised marginal bone level definitely will affect the soft tissue and aesthetic of your case. So before I go into what factors that affect, we have to cover what's normal remodeling, or why the normal remodeling. From the early 80s, we know that bone remodeling is part of normal healing. So we're expecting of about 1.5 millimeter of bone remodeling toward the first thread or toward the implant abutment junction. And then what they have been proposed from early days that 0.1 millimeter annually is considered as normal remodeling. Also, our Bergsten has proposed a similar criteria for success. So why the bone remodeling happens? Because of the supracrystal attachment. That's why we have the bone remodeling to accommodate for the biological width, comprised from the sulcus, connective tissue attachment. So whenever you have an implant with an abutment junction, you will have the bone remodeling up to the point of the abutment implant. That's what we know from biology. So from the point of surgery-wise, if you place the implant deeper, I know that coming of a lot of questions, if you place the implant, they're coming with numbers that you place the implant 3 millimeter deeper, would you have less marginal bone loss? From biology, we know that the bone remodeling will occur either way. So, gonna start directly with the possible factors. I'm gonna divide it into surgical factors, prosthetic and mechanical factors, and soft tissue factors. Put in mind that pre-implantitis factors can be more, like I would not be covering the periodontal disease history, the diabetes, like this. I would be not covering this. I'm just going to focus on what affect the marginal bone. So the first factor from the surgical factor is malposition. So a study by Conical, when they looked at the predictive profiles that can be indicative for any kind of implant tissue breakdown, what they found that the most important factor in their study, actually with an odd ratio up to 48, was the malposition. It showed signs and symptoms of pre-implant tissue breakdown. And when we are looking about immediate implant in freshly extracted site, so you have an immediate implant placed directly into a fresh extraction site, how the position can be predictive of your marginal bone. So they try to look at the correlation between the bucco-oral position. So for each 1 millimeter of the implant being positioned more buccal, you are expecting a vertical bone located around 0.2 millimeter more apically. And also the buccal bone thickness, it's part of the, if you are starting with deficient ridge or you're placing the implant more buccal, so we are talking about the two scenarios here. One of the latest study now, they are just revisiting what's called being the critical bone thickness. So it is actually a canine study. They had two groups. They divided into thin buccal bone, which is less than 1.5, or thick, equal or more than 1.5 millimeter. And also within these two groups, they divided into conventional, that sacrificed the animals at the 8 weeks, and the other group, they introduced pre-implantitis with ligature and true pre-implantitis. They want to see the difference. So on the top part, we have the thin buccal bone, and the lower or the bottom picture is the thick buccal bone. So what they recommended, again, it's a number. I always don't take the number just blindly, but when they are talking about thick or thin, 1.5 could be considered as thick. What they have found that it can be sufficient enough to accommodate for the physiological bone remodeling compared to a thin buccal bone. And the other part, when they introduced the pre-implantitis, also when you have a thicker bone, the signs of pre-implantitis, inflammation, separation, mucosal recession, could be reduced when you have a thick bone. How you can apply this? When you have an implant and you have a thin bone, GBR should always be considered. Another factor is flap versus flapless. We always like talk about trying to go with a flapless. We try to go some flap. In some cases, we have to go with a flap. Does it make a difference? I will start usually if I have a clinical study, then I put the systematic and meta-analysis to show more confidence on the evidence. So this is a study. They had two groups. One test group that they did it flapless, and the control with flap. And it's randomized clinical trial. And what they found that the mean bone level for both test and control was almost around 2 millimeter. And there was no statistical difference between both of them. So what does the systematic review and meta-analysis shows regarding this? So this is one of the systematic review they looked at, and 10 clinical studies were included. Out of the 10, 5 studies showed that there is no difference, and 4 of the studies showed that the flapless could actually be favorable compared to the flap. But in their conclusion, again, the crystal bone level around dental implants and flapless compared to flap didn't show or can be comparable. Another review and meta-analysis And the results of the meta-regression analysis, they showed that according to the results, can be comparable, and there is no statistical difference regardless of what type of the study they were analyzing. So we can say with a high confidence, most likely, there is no difference between the flap and the flapless. Surgical trauma, that's part of the surgical factors. What I mean by surgical trauma is the overheating of bone. So we know that by biology that the bone, the threshold of the bone to have capacity, so when you're drilling, you're actually causing a trauma. So the bone is having a capacity of healing. When you go beyond the 47 degrees, the bone is actually losing the capacity of that healing. So it actually induce or like compromise the marginal bone and could actually lead to implant failure. And one of the factors also is compression necrosis. It's not studied much because it's hard to study the compression necrosis. So this is one of the case studies. They looked at the compression necrosis. What I mean by compression necrosis, when you are applying excessive force to force the implant into a dense bone, that could actually lead to the necrosis of the bone. That's why it's called compression necrosis. Going to the mechanical and prosthetic factors. So mechanical overload. According to the workshop, they're talking about the evidence to support the effect of the overload regarding a healthy implant. In regard of the evidence is scarce and we cannot take a and also a study by NART, when they looked at the occlusal overload and bone implant loss, again, the evidence is poor regarding the evidence supporting the cause and relation effect of the overload. But nevertheless, they will always have, we are talking about the overload regarding marginal bone. Of course, overload can cause prosthetic, like chipping, screw loosening. But from the bone, one of the early paper that talked about the biology of bone remodeling is by Montclair. They talked about how the loading can affect the bone healing. It's actually not the absence of loading. Actually, the loading could be a good thing. If you're not using the bone, usually atrophy could happen. So they're talking about the threshold. There is the threshold of bone to have a negative or a positive reaction. So the absence of excessive loading is essential for implant success. And I apply this when I do my, like sometimes I do immediate implant with immediate provisional. You're always going to have loading, regardless of your occlusion. But what I try to minimize is the micromotion. Having a good contacts can reduce the micromotion. The micromotion could actually negatively affect the implant. I'm going to talk about the microgap. Part of the prosthesis and part of the prosthetic and mechanical factors is the microgap. What I mean by the microgap? Microgap is the gap or the space or the attachment between the implant and the abutment. That's the microgap. You will always have it. If you have any connection, there's always going to be a gap. So the vitro studies that show that the microgap actually can be or work as a reservoir for the colonization of the bacteria that could actually lead to inflammation. Herman did many studies on the microgap, and he looked it into very specific way and very original way. So he looked at, does a stage implant comparable to submerged implant, if like he's talking about either an implant with a healing abutment or a soft tissue, compared to the submerged. Actually, there is no difference. As long as you're doing it perfectly, there is no difference between the both of them. And when you have so on the type A, type B, type C is the non-submerged, and the type D, E, and F are submerged. What they looked at that it's always the bone remodeling follows, if you have like a smooth, or like in the soft tissue, you have a smooth color with a rough surface, it's gonna follow and the junction between the smooth and the rough surface. And if you have an abutment, it's gonna follow the implant abutment junction, regardless. So this study actually showed when you place the implant deeper, it's going to remodel regardless. It's going to have more, but you're going to have the bone remodeling according to the implant abutment junction. So again, will placing the implant deeper prevent physiological bone remodeling? And another study by also Herman, he tried to study the micro gap in more detail. So is it the size that makes a difference or actually the micro motion? And we can apply this study like whenever you're doing you're attaching any kind of attachment, a healing abutment, temporary abutment, try to make your fit good. Don't make it like a micro motion. So when they did the study, so type A and B and C, it's called laser welded. So the attachment is there. So the motion is minimal to scarce. And the type B and E is screw retained. So there is micro motion. And the size of the gap is increasing by A, B, C. So the C is more gap. What they show that, so is it the size or the micro movement is making the difference? It's actually the micro movement. So regardless of the gap size, the micro movement is what's causing the bone remodeling to, or like affecting the marginal bone. So from this part, I think the platform switch, the concept of platform switch can be understandable. Why the platform switch is now the way all the implants companies going. It's actually just to move this gap or move this micro motion away from the bone. So the concept, so when you have a micro gap, if you have platform match, so what I mean by platform match, the implant platform is matching the abutment. So the angle between them going to be increased, like almost 180 degrees or around this. So when you're doing a platform switch, actually, first of all, you're decreasing the angle. So the angle itself is decreasing, and you're pushing away the gap or the attachment away from the bone. So that's the platform switch. So does it work? Does it have an effect on marginal bone? One of the studies, the clinical study by Conical, so they had the implant increasing in diameter, starting from 3.8 up to 5.5, and the healing abutment stayed the same. So there is a mismatch, increasing mismatch, up to the last size. And again, radiographics has been taken at baseline and up to 12 months. What they showed that there is an increase or decrease, sorry, for implant or marginal bone around the implant with the increasing of mismatch. So for the test group 1, the marginal bone loss was around 1 millimeter and decreased into 0.8 in the group 2 and 0.5 into group 3. So all the values is significantly different from the control, which is the platform match. So what their conclusion is that actually marginal bone levels were better maintained than implants having the platform switch concept. And again, whenever I have a meta-analysis, I will show it just to show the confidence level. So this is a systematic review and meta-analysis by Atia that they're following around 643 platform switch implants, and on the other hand, 500 platform matched implants were analyzed. And what they found that 7 out of the 10 articles were in favor of the platform switch, and that the difference was around 0.37 in favor of the platform switch. And what they conclude that platform switching may preserve bone when compared to platform matching. Another systematic review by Annibali also showed the same conclusion, that the platform switch could actually have the upper hand in regard of the marginal bone around implants with favor of 0.5 millimeter. Continuing the prosthetic implant factors is the prosthetic implant connection, internal versus external and conical versus hexagonal. I believe tomorrow Dr. Hadi will be presenting implant connected. He's going to focus only on implant connection. But from the part of marginal bone, for the periodontal part, does it make a difference? Actually, most of the studies shows yes. So internal, now whenever like the science is giving an evidence, implant companies follows. So the internal versus external. So internal, higher mean bone loss for external, around 1.1 compared to the internal 0.2. Another study also by Caruso showed that internal connection seems to show less marginal bones compared to external. And if you're looking about conical versus hexagonal, again, the conical is having the upper hand and showing less marginal bone loss compared to any other connection. Abutment height, this is one of the factors that have been proposed in some studies. Does it have a definitive? We cannot reach to a definitive conclusion, but this is one of study by Blanco. He had many studies on the abutment height. So he had two groups. He had a short healing abutment and a long healing abutment, 1 compared to 3. Does it make a difference? So as you see in the plot gram, we can see that, and there is study that even at the 6 months, the bone loss showed more bone loss around the short healing abutment compared to longer healing abutment. But one of the critique that I have on this paper is that actually whenever you're having a thin or like a thick tissue, when you are placing a thin healing abutment, you're actually causing trauma because you're placing something shorter than the original. But we can take it into our consideration regarding choosing the right abutment height. And abutment disconnection and reconnection, like if you are doing it multiple times, you're taking the abutment, putting the abutment on multiple visits, doesn't make a difference. So one of the latest, I think 2021 of the meta-analysis regarding the effect of attachment or disconnecting on the marginal bone, their conclusion actually multiple or we have multiple attachment, and the attachment could have a negative effect on the marginal bone. It's around 0.9 millimeters, could be not clinically significant, but statistically significant. And regarding the restoration, when I talk about restoration is the emergent profile and the emergence angle. Does it make a difference? Study by Yi, he looked around, at the implants. They had a very large sample. So what they showed that emergence angle actually showed a significant correlation with marginal bone loss. Whenever you're having an emergence angle more than 30 degrees, and when the platform is convex, that negatively affect the marginal bone compared to a less than 3 or a concave profile. And one note to take is this in their study, they could only apply it on bone level implant. Such finding was not found on soft tissue level implants. So the last part of the factors is the soft tissue factors. Does it make a difference, thin versus thick tissue? Lankiewicz has many studies on the tissue thickness. So this is one of the early studies, the clinical studies he did. He had two groups, thin, and now I'm talking about the vertical thickness, thin less than 2 millimeter or thick tissue. And what did that show when you're doing like the X-ray for the evaluation of marginal bone? Thick tissue significantly showed less marginal bone compared to thin tissue. And another study, this time they're not looking about the thickness of the tissue vertically in regard of the thickness of the tissue horizontally, I mean the buccal tissue. And again, what they found out that statistically significant negative correlation were observed between the initial horizontal soft tissue thickness and the change in vertical hard tissue height. So we know that thin could be showing negative. So if you are thickening the tissue, would that affect the marginal bone? So they have one study, they have 3 groups, thin, that's the group A, thin and thickened by allogenic graft, and see which are the control, thick. So they're comparing to the thick. So what they found that in the thin group where they thickened the graft with allogenic soft tissue grafting, there was no difference. So actually thickening the tissue could lead it toward having a positive effect on the marginal bone. Another study by another group, they looked about also the same thing. Will thickening the tissue had an effect on the marginal bone? Again, they have 3 groups and they did the same. And their conclusion was also, and result was also the same. Significantly less bone loss can be seen or observed in thick tissue, and in the group where they have thin, and then thickening of the tissue was applied, also that could have a positive effect. Again, systematic reviews and meta-analysis. Does it make a difference? Yes. A study by Akia and a study by Fernando Suarez. Both of them showed that thick tissue could actually have a less marginal bone. And the meta-analysis by the study by Suarez showed that weight mean difference of 0.8 millimeter in favor of thick tissue group. So we talked about the marginal bone. So is it a magic thing that the platform switch, is it magic that even if you put it in soft tissue, thin soft tissue, if you put it in a thick bone, will it work? No, put in mind that you are comparing to platform matching to platform switching, but still it's not magic. So when you're placing platform switch in thin tissue, again, there will be a difference. So I'm not going to cover the somatic disease in detail because that's part also of periimplantitis, but we all know that any medication that can affect the bone remodeling, an example of high dosage of or IV bisphosphonate or radiotherapy, definitely will affect the marginal bone. And also the smoking, part of it. This is one of the longitudinal studies. They're trying to look only at the marginal bone. So we know that smoking can affect the periimplantitis prevalence, but they're looking around just the marginal bone. Regardless if the implant is healthy or not healthy, again, smokers tend to show more marginal bone. On average, around 0.36 millimeter compared to non-smoker patients. So just to wrap up, we talked about the surgical factors. We talked about how malposition could be associated with signs and symptoms of pre-implant tissue breakdown, how thin buccal bone, bone thickness can affect the marginal bone, and when we compared flap to flapless, there was no difference in high confidence. And regarding the heat regeneration and the compression necrosis, all can affect the marginal bone. And we're talking about the mechanical and prosthetic factors. The overload, put in mind that the evidence is not high, but there is evidence. Microgap and how that can affect the platform switch and the concept. Internal versus external, and the conical versus hexagonal in regard of implant connections. Abutment height, abutment disconnection and reconnection. Over-controlled restoration in regard or in part of the form of emergence profile and emergence angle. And the last part was the soft tissue factors and how the thin tissue compared to thick tissue can affect the marginal bone. So what are the implications? Just to wrap up, how to improve? So ideal positioning of the implant, we talked about the malposition, how it can affect. So the ideal position and the application of guided surgery. If you have a compromised case, guided surgery can aid in this. And routine drill changes. I know sometimes you're overwhelmed or that can come across your mind, changing the drills on a routine basis or to keep tracking to avoid any kind of heat regeneration. Usually heat regeneration is created when you have dull or the settings of the implant motor is not proper, and also proper osteotomy preparation. So try to, I wouldn't say like, so you always have your clinical judgment, but over-prepare your site, especially in length, to avoid any kind of excessive torquing. If you don't want your implant to be above the bone level, if you are talking about bone level implants. And also consider GBR around implants when you are starting with the thin buccal bone. So whenever placing an implant and you are ending up with a thin buccal bone, always consider GBR. And utilizing the platform switch, I know that now most of the implants are going in this way. And choosing the proper healing abutment, not only about for the marginal bone, also for the soft tissue conditioning. When you're using a short healing abutment and you have a thick tissue, you're actually causing trauma. Conical connection could be preferable. And avoid over-contoured restoration in regard of the emergence profile. Always try to make it concave, especially on the first layer of the emergence. And also the angulation, or the angle should be always aiming toward less angle. And also limiting the time of like the abutment disconnection or reconnection, and making sure the abutment is fully seated to avoid this kind of excessive changing. And I think the last thing is considering soft tissue augmentation when there is a thin tissue or the lack of keratinized gingiva. I think I reached to the end. If you have any questions, you are more than welcome. Yes, please. Just wait, I think she will give you the mic so everyone can hear you.
Thank you for the night.
You're welcome.
Abutment height. How, if it is short, it will affect the marginal bone loss, and to how much?
Short mean the healing abutment?
Yes. Is it short like flushed with the soft tissue?
So yes, in this study, my critique was you have a thick tissue, or you're having let's say 4 millimeter or 3 millimeter soft tissue, and you're placing a healing abutment that is shorter than your original tissue. So you're actually causing trauma. So that's my takeout from my critique, or my takeout from this. When I'm talking about their proposal of having a short healing abutment compared to long heal abutment, compared to your original tissue. So you always try to make your healing abutment choice according to the tissue or to the implant dimension. So when you have a deeper implant, you definitely will need a longer healing abutment. That part for the soft tissue conditioning, you're preparing the site for the future restoration, and also you're avoiding any kind of trauma. If you're placing a short healing abutment and you have the tissue is thicker, the healing will not be proper, and you are causing inflammation that could lead the marginal bone.
Another question, please. About the soft tissue thickness, you talk about horizontal and vertical difference. Yani if the horizontal thickness is like 2 millimeters, there is some issue, and if the vertical, can you repeat this?
Yes. So when I talk, or when the evidence talk about the thickness of the soft tissue, some studies look at the soft tissue thickness in the vertical dimension. Like you're calculating from your ridge, vertically where the implant position gonna be, on mid-crystal way, and there they're calculating the vertical dimension of the tissue, and they're divided into thin, thick. Also another way, or another evidence, they're looking at the soft tissue thickness in the horizontal, in the buccal way, not in the vertical and the buccal. So when they have a thin tissue or thick tissue biotype. Both of them could actually have an effect, yes.
Thank you for the nice presentation. I just have a question that you mentioned that flap and flapless, you're saying it doesn't really matter. But I'm sure you would agree that it would come with a condition that the bone thickness was assessed previously by either CBCT or at least by bone sounding. Because sometimes when you take a flap and you find the bone is very thin and it was soft tissue which was very thick. So we should check with the CBCT or at least by bone sounding, right, before we decide on doing flapless.
Okay, but at the end, you will not decide to go flapless or flap according to the buccal bone. If you are starting with a thin buccal bone, you're actually wanting to open a flap to do GBR. That's what we are talking about.
Exactly.
So I'm talking about when they're talking about flapless toward flap. So it shouldn't have an effect in regard of your clinical judgments. If you are placing a flap, you're placing a flap for a reason. First of all, for your angulation, you will have better angulation. And if you are suspecting you are doing GBR. So if you're doing GBR, definitely you have to raise a flap to do your GBR around the implants. But when they're looking around, what's the clinical outcome? So does it make a difference? It doesn't make a difference. What that the high level, some studies definitely will show. As I said in the meta-analysis, most of the studies show there is no difference, but some of the studies shows there is a slight difference in favor of flapless. So in the cases, if you are doing and you are that, you know, that straightforward, you don't need any kind of soft tissue graft, any kind of bone graft, you want to go with the flapless, definitely.
As long as the bone thickness is good, right? Yeah, thank you.
Any other question?
السلام عليكم. كيف؟ مشكور الدكتور أحمد على valuable and heavy ما شاء الله review. My question: how can we avoid the micro movement with the immediate implant, or if we can avoid it, at least how can we decrease it?
Okay. So when I talk about the micro motion in regard to immediate implants, I'm talking if you're doing immediate implants with immediate provisional. So the abutment itself, the motion of the abutment, that's considered the micro motion. So when you're doing immediate implant with immediate provisional, what I've been taught, that you try to make a good contact with the adjacent. Having a good contact with your adjacent will minimize the micro motion. Because loading, even if you take it out of occlusion, when the patient eats, they're always going to be loading. So loading is not the problem. The micro motion of your provisional, that could have an effect. Even if you're doing a full mouth rehabilitation, when you're looking at the studies that are doing immediate loading for immediate implants, they always to go either splint the implants or going with a rigid connection to reduce the micro motion.
Any more questions? يعطيك العافية دكتور.
الله يعافيك.
For your valuable presentation and very informative.
My pleasure.
On behalf of Kuwait Dental Association, I would like to hand you the certificate of appreciation.
الله يعافيك. شكرا.
يعطيكم العافية. We have about like 10 minutes until the next speaker. So if you want to grab a coffee or something, please do.